So, hi, my name is Tomás de Camino Beck. I'm here in Costa Rica, and I am a visiting professor at the Lead University. And as of recently, as I will explain, started working actually for the Pan American Health Organization. And well, I had very different plans for this talk. I was going to give actually a lot of data analysis on the COVID situation in Costa Rica, but since I started last week in the Pan American Health Organization, I am not authorized to do that because I'm now represent the Pan American Health Organization, and any opinion or something I say affects the diplomatic relation in terms of health of the organization and different countries. Since the Pan American Health Organization gives advice to Costa Rica, the government of Costa Rica, and I'm involved now in that team that prepares and analyzes. But the good thing is that before I was kind of an outcast or sort of doing my own analysis as part of as an independent citizen. But now I can do the same thing, but then I think hopefully it will help to get the government to understand and to be able to have good strategies to control the disease. So basically, well, I'll be talking about COVID, and it's a very trendy subject. And COVID is it's a bit of a well, it's a very particular disease, and that's why it hit us rather abruptly and surprisingly. Some of the things that are very makes them very different from other diseases is this being asymptomatic, but in particular being pre-symptomatic, meaning that you can be infecting people but show no symptoms. And in that time, you think you're okay, but you're actually infecting people. The other thing is that it actually travels in aerosol, and then because of that, it's also airborne. And as actually recently was actually confirmed as such that it is actually an airborne virus. So that makes it really complicated. So, and then it's an unknown disease. It's an emergent disease. We don't have a vaccine. So everything kind of add up to something that it's a really large scale and human scale problem. I think beyond that what we have seen from other viruses in the past. And the other thing is that we need to control human population, which is very complicated. Like in other diseases, say for example, H1N1 or something like that, when people get sick, they sort of isolate themselves because they don't feel well. So they feel like I'm going to stay home because I don't feel well. But since COVID, you have this pre-symptomatic period that doesn't happen. So then it's actually, you do have to control human population, not just identify where sick individuals are, but actually control how humans behave and societies behave in order to try to contain or mitigate the effects of the disease. So that brings science, modeling, and politics in the same basket. And it's really difficult because people have this notion that science it's exact and perfect, and you say things and they're absolutely true. And they don't understand that science it's more the way it works, and being able to test ideas and being able to propose ideas that have some evidence or they're grounded in evidence. And then on the other hand, there's politics involved, right? When you put some sort of strategy to control at a human scale, then it's not that simple just to order people to do something that they have not done before. So anyway, so well, basically, one of the main features of this infectious disease that it occurs by contact, meaning that the closer I am to a person, the higher the contact with that person and the higher the probability that I will get infected. So there is, if you have an infected person and you're close to this person and you're okay, then you have a chance, a high probability of getting the disease yourself. So then it moves rapidly by contact between people. So imagine if you go to a movie theater and there's one sick person, and then the movie theater gathers people from that they don't necessarily know each other, but come from maybe from close by places, but they don't really know each other. Then, and you have one sick person, then they all actually also share the air conditioning. It's an enclosed space and so on. So then quickly you get everyone is enjoying the movie, but then when they get home, they turn out they have a high chance that they could have gotten the disease and become infected. And so, and you can see, you have seen all this, right? I'm not going to repeat things that people have already seen. Like this is getting data from this COVID resource data that Wolfram has. It's very useful. And this is just the data from India, and you can see how quickly things start spreading, right? You have confirmed cases, and well, this is just amazing, right? You have say in a few months here nothing much happened, but then suddenly in a few months we're talking about in the millions. So then that kind of exponential growth, and then it turns out and kind of flattens out a little bit. This is confirmed cases. So this may then turn out no more, or should flatten at some point, where you have no more confirmed cases, or the growth decreases. But then this part it's really difficult to control because it moves extremely fast. And well, you have seen all these, all countries has pretty much the same type of dynamics. So what do we need to understand all this, or how we control these things? Well, one of the things is to understand precisely dynamics. And one of the things that I have seen in this situation is that actually a lot of medical doctors are involved in the decision making, and I have not seen so many people in quantitative sciences to be involved in analysis and working on prediction. So we do have to understand the dynamics, the underlying dynamics, to be able to make better predictions for sure. Then we not only need to know the present situation, but then we have to look at the past and see what effect some of the measures may have happened, or what exactly, when there was some sort of an outbreak somewhere, then what particular situation happened that allow that outbreak to happen. And then of course look at the future, right? Because anticipation is the main key in this thing, how to anticipate something that's going to happen, so I can plan the health system to take whatever as many people that it need to take, and then to avoid further spreading of the disease. And well, how do we do that? Well, basically mathematical, statistical, and computational models. Just to, as a matter of fact, as a mathematical biologist, I am a mathematical biologist. In Costa Rica, I didn't have much, I wasn't, there were not too many jobs as such for me as a math biologist, I mean, apart from academia. But then suddenly I became like a hot, right? Because when I started doing my own analysis of the situation, then all these newspapers and media outlets started contacting me because they wanted somebody that could understand the quantitative part of the epidemics to be able to have some more insight, and then to have to interview me for some more information on the disease. So suddenly I became somebody that was really interesting. And then I started receiving calls from everywhere, and for the same reason now I started working at the Pan American Health Organization. And what we need is precisely descriptive, predictive. Descriptive, of course, that's the most common one, just to see those famous cumulative and active cases and number of deaths and so on. But that just tells us what's going on at this point. We need also predictive tools or models that can project what's going to happen in a short or long or midterm or long term. Also prescriptive, which means that something that I can test some strategy and figure out what would be, or optimize it and figure out what would be the best way of applying that strategy. And also retrospective, to see what we did, if it worked, if it's worth doing again, or we should just move on and do some other things. So basically, everything kind of starts with SIR models that are very old, and I did my own model, my own version of an SIR model, which I'm going to present. And SIR models, I don't know, probably many of you know about SIR models because of, this is a Wolfram conference, so people know a lot of math and statistics and computer science. So, but still, I mean, it's a very actually basic or simple, straightforward way of modeling the dynamics. It just assumes that you have a mixture of people that are susceptible and infected in a population, and this population is sort of like a container. So you can imagine that these are just gas particles just bouncing around inside a container, and some of them are infected and some of them can become infected. And then you separate those people that have as different categories, and you put them in different like compartments. So you have people that are susceptible, you have people that are infected, and then they can become recovered or die or something like that. So that's what the name comes from: susceptible, infected, and recovered or removed. And this is that's why these are called SIR model. And basically, there is some way of modeling how infective people infect susceptibles, and it's called the mass action law. Basically, it's like, imagine people just bouncing randomly against each other in a mixture, and then there is then a contact rate, which we can call beta, and then there is a probability of transmission that we can call alpha, and that's how then people move from this compartment to the infected compartment. So basically, people bounce with each other, infected people with susceptible, and then they move from susceptible to infected. Once they become infected, there is a rate at which they become recovered or removed, depending on how you interpret the SIR model. Oops, sorry. Damn it. Okay, so in differential equations, this is a system of differential equations that looks like this. It's actually very straightforward. It's basically what you subtract on this side, then on this compartment, then it moves. So it subtracts here, and then it moves to the infective compartment, and then what it's removed from here moves to the recovered compartment. And these describe the rates of change of each one of the compartments. So basically, you try to solve this or analyze this to understand a bit of the dynamics and the disease. And that's these models. I mean, these models have been really used in different contexts. Like I don't think they have been used the way they've been used now, in the sense that they have been used to study some epidemia or epidemiological phenomena that when it's already over, right? Not when it's occurring at the same time. So that becomes a little bit difficult, because then you get the data on a daily basis, but you don't have the full picture, and you have to then use them to do some forecasting or prediction, which is different from what I think what have been done before. So then they became really popular. Actually, now the general population kind of know what an SIR model is. The good thing is that these models some of the ideas for control come from these models. Like, for example, reducing contact rate, which it's now called social distancing. Basically, what you're trying to do is reduce contact rate. And when you use mask and sanitizing and wash your hands and that kind of thing, basically you're reducing your probability of infection. And then there is quarantines, right, where you actually remove physically people that are infective or show symptoms and remove them from the general population, or even like some sort of, it would be more like lockdowns, where actually you don't even allow people to almost to take the contact rate to almost zero, which you actually almost physically remove them from the susceptible population and leave them in their homes without any contact whatsoever. And from these models, the famous R naught have become popular, and basically you can see it's kind of really straightforward in the sense that if you reduce any of these parameters, which is contact rate and probability of transmission, then of course R naught is going to go down, or if you increase the removal rate, which you can think of more like quarantine, then also this would go down. By the same token, I mean, if this is a removed rate that has to do with death, then if this is very high, meaning that it's a really deadly disease, then R naught is not going to be high because it doesn't have enough time to infect enough people. And COVID is actually not that lethal in that sense, but it is because it infects so fast people, then because of large numbers, you have so many people that can die. And I have done work in R naught, and this is a paper I've written a long time ago. It's actually a very nice method to calculate R naught for very complicated systems of differential equations for epidemiological models. So this is basically an SIR model, and amazingly, I have shown this in the media, and basically, this is the same system of equations you have there, and here I'm just doing a numerical solution. And this is a type of shape you see. You initially, the infected here are red. Initially, you have some population that is susceptible, and then as they become quickly infected, it kind of increases what it looks like to be exponential, and then at some point there is an inflection point and kind of slows down a little bit the infection, but it's because there are no more susceptibles available until everyone is infected. In this particular, this is a sort of a toy example. And as soon as you remove, or people are being removed from the population, then you get this type of shapes that, and here I'm making it really high contact rate. This is the type of shape we're seeing, right? Where we see really fast exponential growth, and then almost in a very short period, it kind of levels out, and then it kind of slowly recovers. And this is the type of curve we have seen with some variations in the sense that it's a hump, and then there's another one increasing in the sense that there are several waves that are occurring, and it's because of the way the COVID transmits. Damn it! Just a second. So I built a different model, a model that could include confinement. So basically I did an SEIR model, which includes the exposed compartment, because in COVID you have this period where you're exposed to the disease, and you're actually infectious, and then you become infected. And it's because the way we're dealing with the disease, when you become infected, it's almost immediately you're quarantined because you're detected as infected, meaning that you're removed from the population. So basically it's the exposed, basically the ones that are actually transmitting the disease in the general population. I include in this model, the strategy is to use confinement as a way of reducing the actual susceptible population. Instead of just reducing contact rate and reducing probability of infection, I actually try to remove part of the susceptible population in order to so they're not available to put it that way for being infected, and then allows for cyclic lockdowns and relaxation events, as I'll show you, and then you can include some other social distancing, hygiene, and confinement, so that you can add these three things. Basically, social distancing and hygiene changes the contact rate and probability of transmission, and confinement, which is the rate at which you put people in lockdown, then also will have an effect on the disease. This is sort of the schematics, or the how it works. You have a basic SIR models, and I'm going to concentrate on the B part, and then you have a rate at which people are confined, which I call delta, and this is sort of a switch function that I'll talk about it in a minute, in the sense that the governments turn on and off this sort of confinement or which are basically lockdowns, right? Decide some levels of lockdown and some implementation of some sort of a human scale or city level lockdowns or something like that. In terms of equations, this is the system of differential equations, basically an SEIR, but then you can see there's this confinement compartment, and there is this exchange between being susceptible and confined, and you can move about these two compartments, and you move to confinement at a delta rate, and you move back to susceptible at a xi rate. This is the model in Mathematica. It's basically the same thing. Basically, this is just with basically some confinement, some way of reducing the available susceptible population, putting them in confinement with some measures, but no unconfinement, and you get this type of epidemiological curve. This is the number of infected people, and this is just some sort of numerical simulation just for display purposes. But basically, you look at this, the shape. It's a little bit different, perhaps, but then you don't get to the entire population, but only here I'm setting the population at 5 million people. But even though you have 5 million people, then not everyone is really susceptible because of this confinement strategy that it doesn't allow everyone to be susceptible and to be infected. And the basic idea to do this model was that there's somebody named Tomás Puello kind of published this, and although I would say he popularized the idea, he didn't actually came up with it, because this is kind of a strategy known in epidemiology. And then he came with this idea of hammer and dance. Sorry, it's dance. And basically that you have a hammer period where you have strong confinements or lockdowns, and then you have a dance period where you relax some of the social distancing measures. And here's some of the things he or this person recommends that you would do. But then when you're hammer, you're actually doing really strong lockdowns, and when you dance, you're allowing some of the normal activity to go back to normal, and just avoiding some of the ones that are really risky, like large gatherings and things like that. So the idea was to use this model to try this out, and basically then you can, with this psi function, you can create something like this where you do hammer and dance, basically where there is no, when this is 1, there is a dance, meaning that people can move back to susceptible. Then when this is 0, people only move to confinement and not to the susceptible population. So this is showing in a period of so many days, 200 days, then you can just have a sort of a dance period, and then back to lockdown, and then back to dance, and back to a long lockdown. And you can change that, right? That you can change how long these lockdown periods are, and then when are they supposed to start, and so on and so forth. The idea of this is to try to assess how long these lockdowns should be. So this applied to this SEICR model, including this switch, you would have something like this. Like this is a sort of a normal kind of really strong lockdown situation. Then you include some. I'm gonna move this, and you include some dance days, right? Here's too short, and then you include some. There you go. You include some dance days. That's a bit too much. I'm gonna just add a little bit. And as you can see, when you have some periods of relaxations of the measures, then you would presumably, if you have not yet got rid of COVID, which would be very hard, then you would get quickly periods of a big hump, again, a new wave. And as soon as you put measures back, then things slowly will start go back to a control situation. So the idea of this model is basically so you can include these switches that allow the start and the end of a lockdown period. And there's some sort of delay in which here it's completely over the lockdown, the relaxation period, and here just starts. It takes a while for both to kind of take effect because people start moving then from one compartment to the other one, and it takes a while for them to get back. And it's indeed something like that, in the sense that when you apply some lockdown measures, at least in Costa Rica, it's not instantaneous results, right? So then there's some sort of delay on that. The problem with this, and sort of almost done here, the problem with this is we have seen the disease only. It's a very complicated control system, and it's a control system at a human scale, right? Where you have a control system that's actually the government and society, and then to system to be controlled is actually human populations, and not only human population, but societies, right? And it's not that straightforward. And you apply some actions that have to do with social distancing, communication, some legal aspects, cultural aspects, socioeconomical aspects, and so on. And not only that, once you have in your system, you have people, the real number of people infected, and then you have something you're observing, which might be different, and it has a lot to do with the testing strategy. So then you're actually behaving in terms of something you're observing, so that has to be understood and analyzed using statistical, mathematical, and computational modeling. And on top of that, you have to have some decision models. It's not just, if R naught or R effective is this value, then do this. It's not that simple. And then you have a desired situation that not only involves health, biosecurity, economy, society, education, mobility, a lot of variables. So it's not so straightforward. See. So there is one other thing that I've been observing, and this is kind of a naive way of presenting it. I'm sort of thinking of an SIR, but now you have somebody that's observing, that doesn't influence the system, just observing. Just imagine doing testing to figure out who's sick and who has the infection. And some of the problems we may have is that it's something like this, right? In this particular situation, this is the actual number of infected. This is the actual epidemiological curve, but you have a limited way of testing. So then say you have high positivity in testing, and what the dynamics you actually see, it's very different from what actually is going on. And you can kind of see that some hump may happen, but then look how deceiving this could be, right? You see here, things are increasing, but it's just a way, because the rate at which you're doing testing, and then you have some sort of saturated way of doing testing. So that has to be taken into consideration. It's not just that we're looking at the number of new cases. That's a measure of the population, and then it's not necessarily a representative a sample of the population. So we have to think of that a little bit further, and not just look at those numbers and think that we're actually seeing what is really going on. So we have to be really careful. And on top of that, we have asymptomatic people that can infect people. They have, I think, a lower rate of infection, but could infect people. So I think that's it. I don't know if there is a one question that says, can you model in super spreading event? Yes, indeed, you could. And that was one of the ideas, that to do this preliminary model, to do that kind of thing, and test some of those sort of heuristics on top of, in terms of what kind of strategy could be best to try to control the disease. In the file section, I left this notebook and some papers and a preprint of that model if anyone is interested. And thank you very much. I think I went over 1 minute.